Hello, dear students. Welcome you all to the Master Nursing classes. In the last session, we have discussed the very important questions and concepts. Similarly, in this today's particular video, we are again going to discuss a very important questions and concept for our upcoming Norcet exam. So here, what you people have to do is to be ready with pen and notebook and take a short notes, and wherever I am telling it is important, please write it 2 times or 3 times and practice it. Okay, and wherever I am telling it is must to remember, try to understand the concept what I am explaining behind that particular question, because it will be very much necessary for your exam and to decide your rank in the mains exam and to shortlist your name in the prelims exam, right? So without wasting the time, we will start the today's session. A very good evening to every one of you all. Very good evening, beta. Good evening. I hope sound everything is clear, right? Right. I think screen is also clear for every one of you, right? So we will start the session. Whoever new to the channel, okay. So who all are new to the channel, so fatapat do subscribe to the channel and hit the like button. We will start. Okay. So almost all, many of you have already joined. So let's begin the session, right? With this particular and powerful motivational quote. Students, whenever you will feel low and whenever you will feel tired, don't stop. Don't stop when you feel tired. Stop when you are done the work. If you are feeling tired, take a rest, but never stop. Never try to quit. So always have the attitude of the never give up. So it will make you a champion in your life. Okay. So if you're feeling tired, yes, you can give some space to yourself. Okay, and some time to yourself and listen some good music, then restart again. Never stop. Okay, you can take rest, but you can't stop. As an aspirant, it is a continuous journey of the learning and acquiring the knowledge and giving the best shot in the exam. So this much is more than necessary and more than enough for your good rank in the exam, right? So without wasting the time, we will start the today's session. And almost all of you have joined with this particular and very important information. Students, in the Master Nursing Classes app, every day we are giving the live test series. So that is as a real-time exam. You will get a real-time exam practice here. That is of the 20 questions for 18 minutes. Total 5 sections, 100 MCQs. In one test. Okay, so this particular test will be live since morning 6 a.m. to 11 p.m. Okay, at 11:30 p.m. Same day you will get a all India rank in our official WhatsApp group and Telegram group. And to join the free Telegram group, you can join to our Telegram group. Link I have given in the description box. And to become a part of this all India level Super 60 test series for Norcet. So if you can download the Master Nursing Classes app, I have given the link in the description box. Okay, so let's begin the session. Here the first very important question is there in front of you all. Which hormone primarily stimulates the glycogenolysis in the liver during the fasting? The simple question, and I want everybody's active participation and active listening in the comment box. Okay, fatafat do answer in our comment box. Yes, which hormone is primarily stimulates the glycogenolysis in the liver during the fasting? So option A, insulin. Option B, glucagon. Option C, somatostatin. And option D, prolactin. So what is the correct answer? Yes, if someone is asking you which hormone is responsible for producing the milk, the hormone which is responsible for producing the milk is the prolactin. So what is the process of production of milk we call as? Yes, the process of production of milk we call as the galactopoiesis. What do you call that one? What is galactopoiesis? Galactopoiesis is the production of the milk through the prolactin hormone. So that is what we call as the galactopoiesis. Okay. So what is the galactokinesis, beta? What is the galactokinesis? Can anyone want to answer? What is the galactokinesis? Galacto means yes. Kinesis means yes. It is a very simple. Galactokinesis means the a movement of the milk from the breast milk to the out. So the galactokinesis will be done by the hormone called as the oxytocin. Yes, which hormone is responsible for the production of the milk? Prolactin. Which hormone is responsible for the movement of the milk? Oxytocin. Okay. And which hormone is responsible for the glycogenolysis? Which hormone is responsible for the glycogenolysis? Yes, option A insulin, option B glucagon, option C somatostatin, and option D prolactin. What is the correct answer? Very nice. So many of you you have given the correct answer. There is the glucagon is the hormone which is responsible for the glycogenolysis. So what is glycogenolysis? Understand. So whenever you will have the food, okay, so it will give some glucose. It will give some glucose. So this glucose, it will get stored in the liver as a glycogen. Okay, as a glycogen. So this glucose is converted to the glycogen with the help of the hormone called as the insulin. Okay, insulin is the very important hormone which is responsible for converting the glucose to glycogen, and it will reduces the blood glucose level. Okay, so it will get reduces the blood glucose level and it will get convert the glucose to glycogen. Okay, so this glycogen, it will get stored in the liver, right? So this glycogen, it will get stored in the liver, right? So whenever the patient is fasting, okay, whenever the patient does not have the food, that time this stored form of the glycogen, it will get converted into the glucose. Okay, so this glycogen, it will get converted into the glucose. Yes, so which hormone is responsible for converting the glycogen to the glucose? So that is our glucagon. Okay, so this glucagon, what it will do, it will break the glycogen. So that is what we call as the breaking the glycogen, which what we call as the glycogenolysis. Okay, so glycogen is breaking and which is making the glucose. So this process is called as the glycogenolysis. So glycogenolysis will be done by the hormone called as the glucagon. Yes. So very, very important. Remember the 4 very important MCQ what I am explaining to you. Yes. Whenever a glucose level will be deficient in the blood, at that time glucagon will activate and it will convert the glycogen to glucose. Okay. So it will breaks the glycogen, it will convert to glucose. Now the glycogen is breaking means what we call that one is the glycogenolysis. Yes, the hormone responsible for the glycogenolysis is the glucagon. And which hormone is responsible for the glycogenesis? Yes, the hormone which is making glucose to the glycogen. So the hormone which is making the glycogen means, so the hormone that is the insulin is responsible for the making the glycogen, means the glycogenesis happens due to the insulin, glycogenolysis happens due to the glucagon. Very important 2 questions directly strike in your exams. Okay, and the next very important hormone, that is the somatostatin. Okay, so somatostatin is the hormone. This is also will be released by the pancreas only. Okay, there are total three cells in the pancreas. One is alpha cell. Alpha cell is responsible for producing the glucagon. Okay, so this glucagon, it will increases the blood glucose level. Okay, it will increases blood glucose level. How it increases? I told it will breaks the glycogen and it will make the glucose, and that glucose will increase in the blood. Okay, so glucagon is responsible for increasing the blood glucose level. Okay, through the beta cells, Langerhans of the cells. Okay, from there the insulin will releases. Okay, from here the insulin will releases. So this insulin is responsible for a decreasing blood glucose level. Okay, this is responsible for decreasing blood glucose level. Okay, and from the delta cells, there is a hormone which releases from the delta cell is that is our somatostatin. We call this hormone also as the growth hormone inhibitory hormone. Okay, so this one, it inhibits both the insulin and glucagon whenever there is a excessiveness is there. Okay, so this is the three very important pancreatic cells. Okay, so which releases the three very important hormones. Yes, the balance of the glucagon and insulin is maintained by the somatostatin. Yes, the insulin is responsible for the decreasing the blood glucose level. Glucagon is responsible for the increasing the blood glucose level. How the glucagon will increase the blood glucose level? Glucagon will break the glycogen into the glucose. Okay, how the insulin will decrease the blood glucose level? Okay, so the insulin it decreases the blood glucose level by making the glycogen. How it will make the glycogen? It will takes the blood glucose and it will makes the glycogen and it will helps to store in the liver. Okay, so this is the very important three questions. Remember and keep in your mind and give the best shot in the exam. Okay, so hope it is clear. And there is one more word you have to remember, that is the gluconeogenesis. Gluconeogenesis, what it means, sir? Whenever there is in the complete loss of the glycogen also. Okay, glucose is decreased, now glycogen activated, glycogen make the glucagon activated, that glucagon break the glycogen and it makes the glucose, so that glucose also decreased. Okay, so due to the continuous fasting by the patient, so entire glucose is empty from the body, so that time our body will start to break the protein, it will start to break the fat. Okay, and it will start to break the stored carbohydrate. Okay, so it will break the protein, fat and carbohydrate. Okay, and it will mix a glucose. Okay, so this is what you call as in the gluconeogenesis, means the new glucose is forming here by breaking the fat and protein. So this is what we call as the gluconeogenesis. Hope it is clear to every one of you. Yes, so the next question is here in front of you all. Yes, which of the following hormone is primarily responsible for the insulin resistance during the pregnancy? This is your very important hormone question. Okay, so this is our very important question, beta. So don't forget this question. Which hormone is responsible primarily for insulin resistance during the pregnancy? Yes, during the pregnancy, so normally there is excessive resistance is there against the insulin function, so the blood glucose level in the mother will get increases abnormally. Okay, so that is what we call as the gestational diabetes mellitus. Okay, so which hormone is that hormone which is responsible for resisting the insulin during the pregnancy? Option A is the progesterone, option B is the estrogen, option C human placental lactogen, and option D is the human chorionic gonadotropin. What is the correct answer? I'm waiting for your response in the comment box. Do comment. Which of the following hormone is responsible primarily for the insulin resistant during the pregnancy? Yes, the correct answer goes to the option C, and many of you have given the correct answer. That is the human placental lactogen. So this human placental lactogen we also call as the human placental somatotropin. Okay, so we also call this one as in the human placental somatotropin. So very important hormone. So this hormone, it is responsible for the insulin resistance. Okay, this is responsible for the insulin resistance during the pregnancy. So against the insulin there is resistance, means so in the mother what happens? The blood glucose level increases. Why? Because there is insulin resistance is there. Okay, so due to the resistance against the insulin, the mother blood glucose level will increases. Okay, so maternal blood glucose level is increasing, means this blood glucose, it will crosses the placenta, and in the fetus also blood glucose level increases. Okay, so remember very important point. Fetus will not produce any kind of the glucose. Fetus is completely dependent on the mother blood glucose. Okay, if the mother blood glucose is high, so it will supply to the fetus. Okay, fetus is completely dependent on the mother glucose. Okay, it will not produce the glucose itself. Very important, keep in your mind, right? So now the fetal blood glucose will increase, but so fetus will have the ability to produce the insulin. Okay, at the 12th week of its intrauterine life. Okay, so 12th week of intrauterine life, fetus will produces insulin. Okay, and mother insulin will never ever crosses the placenta. Remember, the glucose will crosses the placenta, but insulin will never ever crosses the placenta. Okay, so very important thing, keep in your mind, right? So the answer for this question goes to the option C as a correct answer. Yes, and remember the golden point. Okay, so at the what time of the pregnancy there is maximum insulin resistance is there. Okay, so maximum insulin resistance seen at, okay, what time of the pregnancy? Yes, can anyone wants to answer? Maximum insulin resistance seen at what time of the pregnancy? Yes, so it's seen at the 24 to 28 week of the pregnancy. Okay, so very important, keep in your mind. Okay, so this time only, so there is highest chance of the insulin resistance, means there is highest chance of the gestational diabetes mellitus will be there in the 24 week of the pregnancy. Okay, so blood glucose level which is more than, yes, more than normal at the 24 week of the pregnancy, we call that one as in the gestational diabetes mellitus. Okay, so very important, keep in your mind, right? So the next question is like here in front of you. Which of the following hormone plays a major role in the promoting the fetal growth during the pregnancy? So during pregnancy period, which hormone is responsible for the fetal growth? The direct questions will be asked in your exam. The main hormone which plays a major role in the development of the fetus growth. Okay, so not newborn growth. Okay, here they are asking the hormone responsible for growth of the fetus. Very simple question. Option A is the cortisol. Option B is the human chorionic gonadotropin. Option C is the insulin-like growth factor, and option D is the growth hormone. Yes, which hormone is responsible for the growth of the fetus in the intrauterine life? Fatapat do comment your answer in the comment box. I am waiting for your answer, guys. Yes, a few of you have given the correct answer and few of you have given the wrong answer, but a growth hormone is not correct answer. Growth hormone is responsible for the growth after coming out of the mother uterus. In the extra uterine life, the main hormone which is responsible for growth is the growth hormone. But the question is, which hormone is responsible for the promoting the growth of the fetus during the pregnancy? Means the fetus means the baby which is present inside the uterus. So that one what we call as the fetus. Okay, so fetal growth is the main hormone which is responsible for the fetal growth is, that is the insulin like growth factor, goes to the correct answer. Okay, so insulin like growth factor, and insulin is responsible for the promoting the fetal growth during the pregnancy. Okay, so did you heard the word that there is a macrosomia in the gestational diabetes mellitus? Okay, macrosomia. So what do you mean by macrosomia? Macrosomia means a big baby. Okay, macro means big, somia means body. Okay, so big body will be there in the baby. Okay, so which baby we will call the macrosomic baby? If the weight of the baby is more than 4 kg, so that one we call as the macrosomic baby. Okay, so this macrosomic baby will be seen in case of the mother of the diabetes. Okay, in the case of the gestational diabetes, a mother baby will be a macrosomic baby. Sir, why? Why? Because I told in the last question there is a excessive insulin resistance is there at the 24 week to 28 week of the gestation. Okay, so at the 24 week of the gestation, due to insulin resistance, a mother blood glucose is increased and the fetus blood glucose is increased. So the fetus blood glucose is increased. It means insulin production in fetus also increased. Okay, insulin production in fetus also increased. Okay, so insulin is increased means the main hormone which is responsible for the growth of the fetus is the insulin. So there is abnormally increased insulin will be there. So there is abnormally excessive growth will be there. Okay, so I told in the last question the hormone which is very much necessary for the promoting the fetal growth is the insulin like growth factors. Okay, so here in the gestational diabetes, the insulin production in the fetus is increased. So that is the reason increased growth of fetus will be there. Okay, whenever there is when the fetal growth is increased, so which may leads to the a macrosomic baby. Okay, so macrosomic baby means a baby's weight will be more than 4 kg. So this is what we call as the a macrosomic baby, very important. So this is how in the mother of the diabetes mellitus there will be a baby will born big baby. Okay, so that is the macrosomic baby. Very important points, keep in your mind, right? So when the insulin will be produced in the fetus, I already told the insulin will be produced in the fetus at the 12th week of the period of the gestation. Okay, it will be produced at the 12th week of the period of the gestation. Okay, and when we will diagnose the gestational diabetes, after 24 week. Okay, after 24 week of the gestation we will diagnose the gestational diabetes mellitus. Okay, so very important, keep in your mind, right? The next question is awaiting for every one of you here like this. What is the drug of choice for managing gestational diabetes mellitus when the medical nutritional therapy fails? Yes, option is the metformin, option B is the glyburide, and option C is the insulin, and option D goes to the labetalol. Yes, so what is the correct answer? What is the drug of choice for managing the gestational diabetes mellitus when medical nutritional therapy fails? Students, consider there are the two situations. Okay, there are two situations. One situation is already there is diabetes mellitus present in female, and now this female become pregnant. Okay, so this is what we call as in the overt diabetes mellitus. What we call this one is in the overt diabetes mellitus. Okay, right? So this is one situation. Another situation is a lady get pregnant. Okay, so at the 24 week of the gestation, due to the at the 24 week of the gestation, okay, so due to the excessive insulin resistance, he become diabetic. After the pregnancy, after 24 week of the gestation of the means after 24 weeks of the pregnancy, so due to the excessive insulin resistance, she become diabetic. So this particular lady, I call this one as in the gestational diabetes mellitus. Yes, there are the two situations. First situation is already a mother is diabetic and now she become pregnant, so that is what we call as the overt diabetes mellitus. Okay, and another situation, there is a normal woman, she become pregnant now, and after getting the pregnancy, due to the human placental lactogen hormone which creates the excessive resistance against the insulin, due to the resistance at the 24 week of the gestational period, so that time that particular a normal pregnant woman become a diabetic mother. Okay, so that particular condition we call this one as the gestational diabetes mellitus. Okay, very two simple situation. Okay, so in a overt diabetes mellitus and gestational diabetes mellitus, very importantly we need to check two very important points here. Okay, so whenever we are treating the overt diabetes mellitus, means already a diabetic mother, now she become pregnant, so for her there is no role of diet, okay, and exercise in treatment of the overt diabetes. But in the gestational diabetes, the first step is diet modification and exercise. Okay, so very important thing, keep in your mind, in the overt diabetes there is no role of the diet, there is no role of the exercise, but in the gestational diabetes mellitus Yes, the first step is the to make the changes in the diet. So that is the diet modification and exercise. This diet modification and exercise, it will controls the blood glucose level. If it fails, if it fails to decrease blood glucose, then the drug of choice is insulin. Okay, so in the gestational diabetes mellitus, we are making the diet modification. If that diet modification fails, then we will go for the insulin as a drug of choice. But in the overt diabetes mellitus, there is no role of the diet, there is no role of the exercise. Directly, we will start the drug of choice, that is the insulin. Okay, that is the insulin. Very, very important. Keep in your mind. Okay, so already a diabetic mother, now she is on the insulin. Okay, so what we have to change the doses in the pregnancy. Yes, already a mother is there, she is already taking a insulin, and during the pregnancy, okay, so already she is diabetic and already her blood glucose level is more. Now due to the resistance, there is again highest chance of the increase in the blood glucose level will be there. Okay, so that is the reason during pregnancy, okay, so during the pregnancy, what we have to do, increase dose of insulin in overt diabetes mellitus, but only in the second and third trimester. Okay, so because why? Because if she is pregnant and already she is taking insulin, so in the first trimester there is no insulin resistance, so the same dose we can continue in the first trimester. But in the second trimester and third trimester, so there is a resistance against insulin is there, so the more dose of the insulin is required in the second and third trimester, and there is no need of the change in the dose in the first trimester. Remember this very important golden points. Okay, in the overt diabetes, no role of the diet, no role of the exercise, and the drug of choice directly will start as insulin. And during the pregnancy, dose of the insulin will be increased in the overt diabetes, but only during the second and third trimester. No need of increasing the dose in the first trimester. Otherwise, it will lead to the maternal hypoglycemia and the fetal hypoglycemia. That is not good. Okay, so in the gestational diabetes, first step of the management is the diet modification and exercise. If that fails, we will go for the drug of choice as the insulin. Okay, so then comes to the question now. What is the drug of choice for managing the gestational diabetes mellitus when the medical nutritional therapy fails? Okay, so the diet modification failed here. Okay, so now she is a case of the gestational diabetes. Okay, she is not a case of the overt diabetes. She is a case of the gestational diabetes mellitus. Okay, and when she will have the medical nutritional therapy, that is failed to maintain her blood glucose level. So now I told, in the gestational diabetes mellitus, first step is the diet modification, exercise. If it fails, the next dose drug of choice is the insulin. Okay, so what is the correct answer now? The correct answer for this particular question goes to here is the insulin. Okay, insulin is the drug of choice in the gestational diabetes mellitus, and insulin is the drug of choice in the overt diabetes mellitus. A very, very important thing, keep in your mind. Okay, so hope it is clear to every one of you, right? And metformin and glyburide are the oral hypoglycemic agent, OHA. Okay, so if mother refuses the in taking the insulin, because you know the insulin will be given by the which route? Yes, insulin will be given by the which route? Fatapat to comment in the comment box. Which route we will use to administer the insulin? Option A, IV, option B, IM, option C, subcutaneous, and option D is the intradermal. What is the correct answer, beta? Yes, very nice of you all. Insulin will be given by the subcutaneous route. Okay, so that is the very, very important thing. And only one insulin we will give the IV route. Which insulin is that? Yes. Which insulin? Only one insulin we will give the IV route. So which insulin is that? Very nice of you all. Okay, that is the regular insulin we will give by the IV route. Only regular insulin. Other than the regular insulin, so this NPH, okay, human ectopid, mixture, okay. So there are the lots of the insulin type is there along with the combinations. So you can remember. So all the glargines, everything will be given the subcutaneous route, and only one insulin, that is the regular insulin, we can administer through the IV route. Okay, so very, very important. Keep in your mind, right? Hope it is clear. And the mother is refusing to take the insulin. now she don't want to prick like insulin be taken at least 3 times a day. Okay, so before breakfast, before dinner, before lunch, right? And sometimes requirement of the glargine is there after the dinner at the night. Okay, so that is like at least 4 prick per day will be happen to the pregnant woman, right? So if she is refusing to take the insulin means that time you can go for the only two important drug allowed is the Mahatma Gandhi. Okay, so M is the for the Mahatma, that is the metformin, and Gandhi is for the glyburide. Okay, so very important. Remember, only two OHS are allowed in the pregnancy. That is the metformin and the glyburide. Okay, so we can give if the female refuses to take insulin. Okay, if pregnant woman refusing insulin, then only we will give this particular OHS. Okay, so then the labetalol, it is the drug of choice for the pregnancy induced hypertension. Remember, the drug of choice for the pregnancy induced hypertension is the labetalol. Okay, so very important questions and concept. Okay, so by holding the one question, we have discussed the many question here. Okay, so here is the next question is waiting for you all in front of you. Yes, what the response to the question? Which of the following statement about the glucose urea in pregnancy is correct? Yes, the question is very simple and the answer should also come as a very simple fatapat do response. Yes, which of the following statement about the glucose urea in the pregnancy is correct? Yes, the option is the glucose urea in pregnancy is always pathological and indicates the gestational diabetes. Beta, glucose urea in pregnancy is not always pathological. Okay, so it is the physiological. It is normal and it is physiological. Okay, so I told there is normally there is a resistance against the insulin is there that makes the increased blood glucose level, and increased blood glucose level will be there. So there is more glucose will filter out of the kidney, and that kidney will not like renal tubules will not reabsorb the glucose because in the blood there is already high glucose is there. Okay, so that is the reason the glucose will excreted in the urine. Okay, so the like glucose urea in the non-pregnant woman is the pathological. In the pregnant woman, the glucose urea is the physiological. Okay, so during the pregnancy, okay, so glucose urea in pregnancy is the normal. Okay, it is the normal, but the protein urea is not normal. Remember. So the next option B is the glucose urea in pregnancy is never seen and should be investigated immediately. Beta, glucose urea in pregnancy is always seen. Okay, so it will always be seen. Okay, there is no need of the immediate investigation because it is normal condition. Okay, so then comes to the option C, glucose urea in pregnancy can be normal finding. Yes, the glucose urea in pregnancy can be a normal finding and it is very important. Okay, so remember the one word here. So that is the glucose urea is normal, but proteinuria indicates the pregnancy induced hypertension. Okay, so sorry, not pregnancy induced hypertension, it indicates the preeclampsia. Proteinuria in pregnancy. Okay, so proteinuria in pregnancy which indicates the preeclampsia, which is not normal, it is in the abnormal. Okay, so it is an abnormal. Remember the very important thing. So glucose urea is normal, but the proteinuria is abnormal. Okay, so proteinuria indicates the preeclampsia here. Okay, so very important thing. Just you have to keep in your mind. And here is the next question. Which of the following statement about the glucose tolerance test in the screening of the gestational diabetes mellitus is correct? Yes, the question is very simple. Which of the following statement about the glucose tolerance test GTT in the screening of the gestational diabetes mellitus is correct? Option A 75-gram oral glucose tolerance test done daily. Beta, no need of doing it daily. So whenever the mother will come for the first visit, in the first visit, done, one time done, and we have to remember her to repeat that one during the 24 to 28 week of the gestation. Okay, so first time will be done in the first visit, and second time we will do in the 24 to 28 week of the gestation, because this time there is highest chance of the insulin resistance. So in order to assess that one, we will advise in the 24 to 28 week of the gestation, but not done daily. So I am eliminating the option A. Then comes to the option B. Only a 1 hour glucose value is measured in the 75 gram of the OGTT. Better no. So it is for the 2 hours, not for the 1 hour. So I'm eliminating the option B. Okay, so it is on the 2 hour 75 gram oral glucose tolerance test. Okay, not for 1 hour. Right? I am eliminating the option B. Then comes to the option C. A 75 gram glucose tolerance test is typically performed between 24 to 28 week of the gestation. Yes, so it must and it should be done during the 24 to 28 week of the gestation, because this particular time only there is a highest amount of the human placental lactogen will be released, and it will be show the highest resistance against the insulin at the time of the 24 to 28 week of the gestation. Okay, so this goes to the correct answer, right? So the question was asking the screening of for the gestational diabetes mellitus is correct. Okay, so the which question is correct? The option C goes to the correct answer. Okay, so GTT is not used in the diagnosis of the GDM. Better GTT is used in the diagnosis of the GDM. Okay, so how, sir? How means? Yes, let me explain. So look at this particular very important thing. Whenever the pregnant woman, okay, if she comes to the OPD, so in the OPD only we will do the oral glucose tolerance test. So this one we also call as the oral glucose challenge test. Okay, so here what we will do? Here we will give the a 75 milligram of glucose. We will give this one orally. Okay, with 300 ml of water. Okay, with 300 ml of H2O, and we will wait for the 2 hours. Okay, so after the 2 hours we will check the blood glucose level. Okay, after the 2 hours we will check the blood glucose level. Okay, if the blood glucose level is less than 140 milligram per deciliter, so this is the normal. Okay, this is the normal. If the blood glucose is between the 140 to the 200 milligram per deciliter, so this is what we call as the gestational diabetes mellitus. Okay, so if it is more than 200 milligram per deciliter, so we call this one as in the overt diabetes mellitus. Okay, so hope it is clear to every one of you. Yes, so whenever the mother comes to the OPD, okay, so in the OPD only oral glucose tolerance test or the oral glucose challenge test will be done. Okay, so that is that 75 mg of the oral glucose we will give with 300 ml of the water, and we will ask her to wait for the 2 hours, and after 2 hours we will take the blood glucose level. Okay, if it is less than 140, that is the normal. If it is 140 to 200, that is the gestational diabetes mellitus. If it is more than 200, that is the, yes, very very important, that is overt diabetes mellitus. Okay, so don't forget this one, very very important for you all, right? So hope this is clear to every one of you, and the oral glucose tolerance test is used to diagnose. Okay, we will use this one to diagnose. Okay, so hope it is clear clear to every one of you. And here is the next question for you all. Yes, which of the following is the best test to predict the risk of the congenital malformation in a fetus of a mother with gestational diabetes mellitus? Beta, there is a word you can focus, that is the predict. Okay, so there are the two words, one is predict, another one is detect. Okay, so just now try to answer your correct answer in the comment box, and I will tell what is the correct answer actually. Which of the following is the best test to predict the risk of the congenital malformation in a fetus of a mother with gestational diabetes mellitus? Okay, so option is the HbA1c in the first trimester. Option B, oral glucose tolerance test at the 24 to 48 week of the gestation. And option C, fasting blood glucose level in the third trimester. And option D is the TPA scan. Yes, what is the correct answer? Correct answer for this particular question goes to the option A, that is the HbA1c as a correct answer. Beta, TIPA we will use to detect a fetal congenital anomaly at the 18 to 20 week. Okay, at the 18 to 20 week we will use the targeted imaging for fetal anomaly. Okay, so during the pregnancy, so that is the TIPA scan is the best scan to detect the fetal anomalies and the congenital malformation during the pregnancy, that is at the time of the 20 to 18 to 20 week of the gestation. But to predict the risk of the congenital malformation, we will use the HbA1c. Okay, so consider she is a pregnant woman. Okay, so now she is at the 14 week of her pregnancy. She comes to the OPD now. Okay, so in the OPD, she is asking you, nursing officer, please tell me, please tell, I am having the gestational diabetes mellitus. That is the I am having the overt diabetes mellitus. Okay, it means she is already diabetic mother. Okay, she got the pregnancy. Okay, so what is the risk of the my baby is getting the congenital anomaly? Okay, so how you will tell? You have to tell that. So there is a risk is there. How, sir? How means she is already a overt diabetic case, overt diabetic mother case. Okay, means her first trimester, in the first trimester, organogenesis happens. Organogenesis happens in the first trimester. Okay. In the overt diabetes mellitus, in the first trimester only blood glucose is very high. Blood glucose is high in the first trimester in the overt diabetes mellitus. But in the gestational diabetes mellitus, due to the placental lactogen resistance, after the 24 weeks, there will be a increased blood glucose level. Means in the first trimester, there is no any high blood glucose level will be there in the gestational diabetes mellitus. But in the overt diabetes mellitus, in the first trimester only, there is highest blood glucose level will be there. Okay, so now she came at the 14 week. Okay, and she is asking the question like, sir, what is the risk of the congenital anomaly? And we have to say that how you have managed the blood glucose level in your first trimester. Based on that one, the risk we can predict, the doctor will tell. Okay, so sir, she will ask, sir, how I have to know that how I have managed the blood glucose level in my first trimester, means that is in the 3 months back. Okay, so we have the one test that is in our lab, that is the HbA1c. Okay, this HbA1c, it will tell last 3 months. Okay, it will tell a last 3 months or the last 90 days blood glucose level how we have managed. So that one will be explained by the HbA1c. Okay, in the first trimester, if she managed the blood glucose level normal, means so there is a less chance of the congenital anomaly. Okay, but if she have managed the blood glucose level like very negligibly in the first trimester, so there is highest risk of the congenital anomaly. Okay, so what we have to tell to her, if HbA1c value is less than 6.5 in first trimester, there is less chance of congenital anomaly. If HbA1c she is managed more than 6.5, means she had the mast gulam jamuns and all. Okay, so if it is more than 6.5, okay, in the first trimester, there is highest risk of the congenital anomaly. Highest risk of the congenital anomaly. Okay, so beta, this will be specially in case of the overt diabetes mellitus. Okay, so remember the difference between the overt diabetes mellitus and the gestational diabetes mellitus. Okay, so I will write here overt diabetes mellitus and gestational diabetes mellitus. Okay, so this is the basic difference you have to understand between these two. So it will be very much helpful to you all. Okay, right? So understand this one. In the overt diabetes mellitus, what happens? She already a diabetic lady, she got pregnant. Means in the first trimester, okay, in the first trimester also, high blood glucose is there. And in the second trimester, also high blood glucose is there. And in the third trimester, also high blood glucose is there. After the pregnancy, okay, after the pregnancy, also high blood glucose will be there. Okay, so especially during the first trimester, she is having the high blood glucose level, means there is more free radicals will be there. Okay, more free radicals. Okay, so these free radicals, you know, in the first trimester only, there will be organogenesis will happens. Okay, so organogenesis happens in the first trimester. So in the first trimester, there is more glucose will be there in the overt diabetes mellitus. Okay, so more free radicals are there. So that free radicals will damage the fetus, and there is highest or increased risk of congenital anomaly. Okay, so there is increased risk of the congenital anomaly will be there. So due to this congenital anomaly, there is increased risk of the first trimester abortion. Okay, first trimester abortion also there is increased risk. Okay, so in the GDM, what happens in the first trimester? Before pregnancy, there is normal blood glucose level. In the first trimester, blood glucose level is normal. Okay, so it increases after 24 week. Okay, it increases after 24 week of the gestation. Okay, so after 24 week means till that the organogenesis have been completed. Okay, so in the first trimester, there is normal blood glucose level, means there is no any chance of congenital anomaly. Okay, so no chance or the low chance we can write. Okay, so we can write as a low chance, not no chance. Okay, so there is low chance of congenital anomaly because the blood glucose level in the GDM will increases after 24 week of the period of gestation. Okay, so this is the very important point, and there is no risk of first trimester abortion. Okay, so there is no risk of the first trimester abortion. Very important thing, keep in your mind, right? So in the gestational diabetes mellitus, low risk of the congenital anomaly and the low risk of the first trimester abortion will be there. In the overt diabetes mellitus, due to the high blood glucose level in the first trimester, okay, so there is increased risk of the gestational congenital anomaly will be there, and the first trimester abortion will happen due to the congenital anomaly. Okay, so this is the very important thing. And here after the 12 week blood glucose level becomes normal. Okay, so after 12 week, here not comes to normal, blood glucose level not comes to normal. Why? Because before the pregnancy also she is diabetic, during the pregnancy also diabetic, means after the pregnancy also she becomes diabetic. But in the gestational diabetes, due to pregnancy she becomes diabetic. When the pregnancy completes, so her blood glucose level comes to the normal. Okay, so we have to keep in our mind very importantly. So these are the very important and highlighted difference between the gestational diabetes and the overt diabetes. So this question may directly strikes in your exam. Okay, so I told if the lady comes in the third trimester, okay, or the second trimester, and she is asking what is the risk of the what was the percentage risk of the our baby is getting the congenital anomaly, means it is based on the HbA1c value. Okay, so if the HbA1c in the first trimester in the overt diabetes mellitus is less than 6.5, means less chance of the congenital anomaly, means in the first trimester she have taken the good insulin on the regular time, and she have maintained the good diet to reduce the blood glucose level, means she have maintained the blood glucose level to the normal, means there is a less chance of the congenital anomaly will be there in the first trimester. Okay, if the HbA1c is more than 6.5, means so she have not taken the insulin regular time, and the blood glucose level will be very high, and the free radicals will be very high. So that free radicals in the first trimester will make the congenital anomaly. Okay, in the overt diabetes mellitus. So best investigation to predict the risk of overt congenital anomaly is the HbA1c. Okay, and the best test to detect is the TPA scan. Okay, so TPA scan will be done at the time of the 18 to 20 week of the period of the gestation. Okay, very important questions and concept, just you have to keep in your mind. Okay, so the next question is here: what is the most common congenital malformation in the fetus of a mother with gestational diabetes mellitus? The most common congenital malformation in a fetus of a mother with gestational diabetes mellitus. Okay, so option A is the neural tube defect, option B is the cardiac anomaly, option C is the renal agenesis, and option D is the limb deformity. What is the correct answer? Most common congenital malformation in the fetus of the mother with gestational diabetes mellitus. Okay, so the answer goes to the yes. Fatapat do comment in your comment box. I'm waiting for your answer. Yes, is this neural tube defect or the cardiac anomaly or the renal agenesis or the limb deformity? Yes, fatapat. Limb deformity or the limb agenesis or the limb reduction. That is the phacomelia. So we will get, sorry, phocomelia. So this is due to the thalidomide. Okay, so this is due to the thalidomide drug teratogenic effect. Okay, so renal agenesis, this is due to the ACE inhibitors. Okay, so ACE inhibitors during the pregnancy, there is the pills, the captoprils, ramiprills, enalaprils. If the pregnant woman is taking the ACE inhibitors, that is the pills during the pregnancy means, which makes the renal agenesis. Okay, so the most common congenital malformation in the fetus with the diabetic mother is the cardiac anomaly is the first best answer. Okay, so which one is the most common cardiac anomaly means, that is the ventricular septal defect goes to the correct answer. Okay, so ventricular septal defect, and the neural tube defect is the second most common, okay, congenital malformation in the baby with the like gestational diabetes mother. Okay, so here are the very important questions you may get directly in your exam. The risk of the congenital malformation in the baby of the diabetic mother. Okay, so most common organ system involved is the, yes, the first is the cardiovascular system. Okay, in the cardiovascular system, which one is the most common congenital anomaly? That is the okay, so it's the ventricular septal defect, right? So the second most common organ system involved is the neural, okay, central nervous system. Okay, so the second most common is the central nervous system, right? So most common congenital anomaly involved here is the neural tube defect. Okay, so very important, keep in your mind. So the first best answer is the most common is the ventricular septal defect, and the second most common, okay, so most common congenital anomaly, that is the second is the neural tube defect. Okay, so second is the neural tube defect, very importantly, keep in your mind. Okay, so the next one is the most specific congenital anomaly is the, yes, the most specific congenital anomaly in a baby of the diabetic mother is, yes, that is the sacral agenesis. What is the correct answer? That is the sacral agenesis. Okay, so we also call this one as in the caudal regression syndrome. Okay, so caudal regression syndrome also we can say, or the sacral agenesis also we can see. Yes, the golden point chanting, fatapat do revision. The most common organ system involved in a congenital anomaly in a baby of the diabetic mother is, the first one is the cardiovascular system. In that one, the most common congenital anomaly is the ventricular septal defect. Okay, so most common organ system involved, okay, in the baby of the diabetic mother. The second most best answer is the central nervous system, and in that one, neural tube defect is the most common congenital anomaly. Okay, so that's the second best answer, right? The most specific congenital anomaly in the baby of the diabetic mother is the sacral agenesis or the caudal regression syndrome. Okay, so these are the very important questions for your practice. Okay, so the next question is there in front of you all. Yes, the question is very simple, and I am waiting for your response here, beta. Which of the following is the common complication associated with gestational diabetes mellitus in a mother, except one? So this is the question related to the gestational diabetes mother common complication. Yes, the most common complication associated with the gestational diabetes mellitus in a mother. Yes, except one. Option A, hyperglycemia. Yes, in a mother there will be a hyperglycemia. Okay, so there will be a maternal hyperglycemia. Increased blood glucose level will be there. Yes, it will be there. So due to the increased blood glucose level in the mother, okay, so glucose is increased means risk of infection increased. So there is highest chance of the urinary tract infection and vaginitis. Okay, so due to this urinary tract infection and vaginitis, there is highest chance of the preterm labor will be there. Okay, so very important. Okay, so the hyperglycemia is also a complication in the gestational diabetes mellitus. Preterm labor is also a complication in the gestational diabetes mellitus. Okay, so very important. The next one is the polyhydramnios. Yes, there is a maternal blood glucose level increased means fetal blood glucose level also will increases. Okay, so fetal blood glucose level is increasing means yes, fetal will produce the more urine. Okay, fetal will produce the more urine. Yes, the urine is the main source of the amniotic fluid. You know, more urine means more amniotic fluid. Okay, more amniotic fluid. More urine means more amniotic fluid. More amniotic fluid means we call that one as in the polyhydramnios. Okay, so polyhydramnios is also complication, and preterm labor is also complication, and hyperglycemia is also complication. Okay, so due to the more amniotic fluid, there is also due to the polyhydramnios, so there is chance of the premature rupture of membrane. Okay, so premature rupture of membrane may leads to again a preterm. Okay, so again which may lands into the preterm labor. Okay, so this will be a very important two causes of the preterm labor. One is the polyhydramnios, which will lead to the premature rupture of the membrane, and premature rupture of the membrane which will lead to the preterm labor. Okay, so but the postterm labor will not happen as a complication in the gestational mother with a gestational diabetes mellitus. Okay, so this one goes to the correct answer. Okay, so the question asked here is the except one. Okay, except one means except the postterm labor. Okay, except the postterm labor, all the things happens here, and the correct answer goes to the option D, goes to the correct answer here. Okay, so very important, keep in your mind. And here is the quick revision of the maternal complication in gestational diabetes mellitus. The maternal complication, very important thing, I told the hyperglycemia. Okay, so due to the hyperglycemia, I told there is increased risk of the urinary tract infection. Okay, urinary tract infection and vaginitis, UTI and vaginitis. So due to this UTI and vaginitis, there will be a preterm labor. Okay, so second most common complication will be the preterm labor. Okay, and due to the hyperglycemia, so there will be a fetal hyperglycemia. Fetal hyperglycemia means there is more urine production in the fetus. More urine production means that will be a polyhydramnios will be get. So due to the polyhydramnios, so there will be a preterm rupture of membrane. Okay, due to the preterm rupture of membrane, again the preterm labor will be chances there. Okay, so the polyhydramnios means there is distended uterus. Okay, distended uterus will be there in the mother. Okay, so distended uterus means the big uterus. Big uterus means big uterus. Big uterus means it bleeds more. Okay, it bleeds more. Okay, big uterus bleeds more means there is highest chance of the postpartum hemorrhage. Okay, so PPH risk will be increased. Okay, so if the mother is having the gestational diabetes mellitus, means there is chance of the pregnancy induced hypertension also will be there. Okay, so chance of the pregnancy induced hypertension is also will be there. Okay, so these are the important maternal complication: hyperglycemia, okay, which leads to the UTI and vaginitis, and preterm labor, and polyhydramnios, which leads to the preterm rupture of membrane, and the distended uterus, that is the big uterus which bleeds more. Okay, which bleeds more means there is a PPH. Okay, these are the complications seen in the mothers of the gestation, like mother who is having the gestational diabetes mellitus. Okay, so next in the fetal complication, I told in the fetal complication, very important thing just need to remember is the again fetal hyperglycemia will be there. Okay, so more blood glucose level in the mother means more blood glucose in the fetus. Okay, so in the fetus also we will get the hyperglycemia. Fetal hyperglycemia will be there. So due to this fetal hyperglycemia, so there is the, I told, a main hormone which is responsible for the growth of the fetus is the insulin. Okay, so there is excessive glucose means the fetus pancreas, fetal pancreas produces more insulin, right? Which produces the more insulin. If the more insulin means the baby will grow more. Okay, so baby will grow more means we call that one as the macrosomia. Okay, so macrosomia means weight of the baby will be more than 4 kg. Okay, so the macrosomia means all the body weight of the baby will deposit at the shoulder level. Okay, so because of this hyperglycemia there will be a macrosomia, second complication, and this macrosomia which leads to the shoulder dystocia. Okay, so shoulder dystocia also will be seen, means difficulty in the delivery of the shoulder. Okay, so sometimes the fetus may land into the intrauterine fetal death or the intrauterine demise of the fetus. Okay, so there is the may the complication happens during the fetal complication, and sometimes there is a chance of the, yes, stillbirth. Okay, just keep in your mind. So hyperglycemia leads to the macrosomia leads to shoulder dystocia leads to the like there will be a chance of the stillbirth and the intrauterine death of the fetus. Okay, so these are the fatal complication will be seen in the fetus of the gestational diabetic mother. Okay, so the next newborn complication, beta, I told she is the mother. Okay, consider she is the mother, and here is the fetus. Here is the fetus, right? I told fetus is completely dependent on the mother glucose. Okay, when the mother will send the glucose, that time only fetus will have the glucose. Okay, so that time only fetus will comes to the glucose will comes to the fetus. Okay, so how it will comes means it will comes to the umbilical veins to the fetus, it will come, right? So now in the intrauterine life there is more glucose is there in the diabetes of the pregnant woman, so that time there is more glucose will be supplied to the fetus. So the more glucose is supplying to the fetus means, so that time what happens, the fetus will produces the more insulin, fetal will produces the more insulin, but immediately after the birth, okay, in the newborn what we will do, we will cut this umbilical cord. Okay, we will cut this umbilical cord means we will stop the glucose supply to the fetus. Okay, so glucose supply is the stopped means blood glucose level will decreases, but and again there is a more secretion of the insulin is there, further blood glucose level will decreases. In the newborn what happens, in the newborn what happens, hypoglycemia will happens in the newborn. Okay, remember, in the mother hyperglycemia will happens, in the fetus hyperglycemia will happens, but in the newborn hypoglycemia will happens. This is your exam question. Okay, so this is your very important exam question. Okay, MCQ very important, you will get in your exam. Okay, so remember. Then I told here there is a chance of the preterm rupture of the membrane, and I told there is a polyhydramnios means there will be a chance of the preterm labor. Okay, so there will be a chance of the preterm labor. So due to the preterm labor and the premature birth of the baby, so there is a chance of the respiratory distress also. Okay, there is chance of the respiratory distress in the newborn. Okay, so very important two things we have to keep in our mind. One is there is highest chance of the newborn hypoglycemia, and there is highest chance of the respiratory distress syndrome due to the preterm labor. Okay, so these all things we have to keep in our mind as a newborn complication, as a fetal complication, and as a maternal complication. Yes, so what happens in the mother? Okay, so gestational diabetes mellitus case, in the mother what happens, the blood glucose level hyperglycemia. Okay, so there is hyperglycemia. What happens in the fetus? Again there is in the hyperglycemia. And what happens in the newborn? In the newborn there is a highest chance of the, yes, right in capital. So this is our exam question. Okay, so in the newborn there is hypoglycemia. Okay, so very important. Why sir hypoglycemia? I told so initially in the intrauterine life the fetus is getting lots of the blood glucose from the mother. So now after the birth umbilical cord is cut, the glucose supply is cut, but the newborn is secreting excessive insulin. Due to that one there is chance of the hypoglycemia. Okay, so very important thing you have to keep in your mind. Okay, so along with that in the newborn complication you will get all the hypo. Okay, hypocalcemia, hypomagnesemia. Okay, so and hypokalemia. Okay, so potassium also decreases, magnesium also decreases, and the calcium also decreases. Okay, so hypokalemia, hypomagnesemia, hypocalcemia you will get. Okay, along with that you will get a polycythemia. Okay, so but no anemia. Remember, diabetic mother newborn will have no anemia, but there is chance of the polycythemia will be there. Okay, so keep in your mind. So these are the very important points in your notebook. You should and must, and you should revise immediately after the class. Okay, so this will be helpful for your proper revision, right? So here is the next session we will continue. Okay, so remember the whatever the points I have told in this particular class. So this every point is very much important to all, and here is the assignment to every one of you. So take assignment. Just mention drug of choice for gestational diabetes mellitus, drug of choice for overt diabetes mellitus. So the both answer goes to the same. So which answer is that? And mention. Okay, and second assignment, glucose crosses placenta. Yes or no? Okay, so just mention yes or no. And third question, insulin crosses placenta. Just mention yes or no. Okay, so I hope today's session you people enjoyed. Okay, so I want your answer in the comment box at the end of the video, and I hope you have learned the lots of the concept here. And in the tomorrow session we will discuss again related to some very important questions related to the pregnancy induced hypertension, eclampsia, preeclampsia, severe preeclampsia, mild preeclampsia. Okay, MGSO4 and labetalol, lots of the thing is there. In the next session we will continue. Okay, so in the today's session I hope you people have enjoyed, and the golden point chanting and revision we have done as well as must. Okay, so in the next session we will cover definitely one question will strikes from the today's session fixed in your Norcet 9 exam. Okay, so immediately revise this whatever the content I have given. Okay, after the class. Okay, it will be helpful for every one of you. Okay, so hope you people enjoyed the class. We will continue the class in the next class. Okay, so thank you so much for watching the video, and if you are new to the channel, so please subscribe to the channel. Okay, and hit the like button and share the video with your friends. Okay, so here we are giving the quality content without wasting a 0% of the time of the aspirants. Okay, so hope you people enjoyed the session. Thank you so much for everyone for watching till the end, and put the class in our WhatsApp status and let us grow. Okay, so we will meet in the next video. Tab tak ke liye, Jai Hind, Jai Bharat, bye bye. Thank you all.